Good morning, everyone. Welcome to this. So I'm just going to give a very brief introduction and then hand on to our presenters today for you all. Hopefully that's coming up. So this is the agenda for this morning. We've got 4 presenters on the line, and then we will have time for a panel Q&A at the end. And that brings me to our questions. So hopefully you'll have some questions throughout the webinar. In the panel at the right-hand side of your screen, you should have a questions sort of bar there. If you click on that, you can type questions in and send us as many questions as you like. If we don't get to answering all your questions during the webinar, we will circulate any answers to outstanding questions afterwards. And we will also circulate with that a short feedback survey that it would be great if you could fill in, get a sense of what people thought and make progress for the next webinar. And if you have any technical problems throughout the webinar this morning, my colleague Robbie is on the line and will try and help you deal with any issues there. So again, if you stick those in the question or the chat box, we will try and help. And we'll also circulate any resources that our presenters talk about during the webinars that we will send around to everyone. So from me, and I will hand over. Hazel is going to be we're looking at smokers with mental health conditions during the COVID pandemic. Hazel, it says you are self-muted. You need to just click you're on mute.
There we go. Sorry, it wasn't letting me unmute myself. I don't know why. Thanks, Vicky. Hopefully everyone can hear me loud and clear. I was getting a bit of breakup on Vicky there, but hopefully the slides were conveying anything that people couldn't hear. So I'll just repeat that, do add questions into the sidebar and we will respond to them at the end. So I'm going to kind of whip through some stuff on COVID and smoking and end with some data, some new data on smokers with mental health conditions and what we know they are doing in response to the current crisis. So just to start by hopefully moving on to the next slide. There we go. Just to talk a bit about what we know around the evidence on smoking and COVID. This is, obviously a novel virus, and there's still a great deal of uncertainty about, a whole range of things to do with this virus, and its interaction with smoking is one of those things. However, there are things that we can draw from the evidence to date. So it does appear that smokers are more likely to report symptoms of the symptoms of COVID-19, and that's perhaps unsurprising when you think of some of these symptoms being around things like coughing, which clearly smokers are more likely to do than other people, and they're also more likely to have a whole range of infections. But it does appear from the evidence in the UK and around the world that they might be a bit less likely to test positive. So that might be one of the theories around that, is that could be because they're more likely to be tested in the first place because they present with COVID-like symptoms that are not COVID. We have some relatively good data, and I would stress that none of the data that we have so far is as good as it might be, because clearly it's emerging, and this is a situation where gathering data is challenging. But the data that we have from around the world around smokers once they're hospitalised is suggesting that they have worse outcomes than people that don't smoke. So broadly, the message is that it would be better to quit smoking. There has been a hypothesis that's been posited that nicotine might be acting as a protective factor in relation to the development of COVID or worsening conditions. This is very much an unproven hypothesis. It is being tested. So there are research projects underway in France in particular using nicotine replacement therapy. But it's certainly not a reason for people not to quit smoking at this time. The known risks of smoking and smoking-related illnesses like COPD and diabetes and other conditions have been associated with worse outcomes from COVID. So we know what the risks are of smoking, and people should. It's always better to quit. But one of the things it might provide us with is an additional incentive to use alternative sources of nicotine when trying to quit. And we know that when smokers use other sources of nicotine, they're much more likely to quit successfully. So this is something we would want to see smokers do anyway, and perhaps it provides an additional rationale for doing so. I would say that's a very light touch discussion of the evidence that we have so far on smoking and COVID. We have some FAQs on the Smoke Free Action website which go into this in more detail, and they draw heavily on a living review which colleagues at UCL and the Royal Veterinary College are updating every fortnight, and we are updating our FAQs in line with their findings as well. So just to move on, what else we know about kind of COVID at the moment. So the notion that we are all in this together is clearly not true, and I think the media reports are really reflecting this now. Some communities are paying a much higher price for both in terms of illness and in terms of the impact of lockdown. So clearly the rates of illness and death are much higher among those experiencing disadvantage and clearly those with existing conditions. It's the lockdown experience is disproportionately impacting on those who are already living in disadvantaged circumstances. So it's the jobs of people on low incomes and those who are low paid who have been really badly hit. And that the people living in the areas and in the communities that had the poorest health going into lockdown are also seeing an exacerbation of unhealthy behaviours as well, which is likely to exacerbate problems going forward relating to COVID and other things. And those with existing health conditions have also seen their access to the NHS reduced. I mean, hopefully we're coming out the other side of that, but we know that, for example, things like cancer diagnosis remain very depressed with people not seeking medical help. And again, this is going to hit our smokers harder, and in particular our smokers with mental health conditions who are more likely to need healthcare for other conditions other than COVID. And of course, people with mental health conditions already have problems in terms of accessing support with their physical health. So why do we need to take action to support smokers at this time? Smokers can improve their health and well-being by quitting, and they may reduce their risk of COVID-19 exacerbation. Smoking is the leading cause of premature death and disease experienced by people with a mental health condition, and getting people the massive inequalities. I'm sure that if you're listening to this, you're already aware of that are caused by smoking among people with a mental health condition. Something that is a stated government objective to address, and something that we need to do now more than ever. Smokers are significantly more likely to be unemployed and to be earning less, even when controlling for other factors. So they're much more likely to be on the receiving end of some of the impact of lockdown and any future recession. And again, our smokers with mental health condition are often at the bottom of the pile. So we have research that was done by Nottingham University a few years ago showing that around 1 million smokers with mental health conditions are living in poverty or were living in poverty when that research was conducted. So extremely vulnerable to the impact of lockdown and recession. And again, quitting not only can benefit people's health and mental health, but also their economic circumstances. So, you know, we need to be looking to reduce the burden of ill health right now across the system, you know, to support the NHS. But also as we're thinking about how we build resilience in the population and particularly help those most disadvantaged communities, this has got to be part, you know, addressing smoking has got to be part of how we are going to recover from this pandemic. I'm going to talk a bit more about the kind of lockdown legacy in terms of poor health with some of the data I'm going to show, and thinking about how, you know, if we have clearly, you know, cancer I think is the most striking example in terms of, you know, the health problems in the system that are storing up because people have had less access to the NHS, and getting smokers to quit who are coming to the NHS with health conditions like cancer can improve their outcomes. And we need, I think, to see smoking as part of building a healthy economy and a healthy financial future for our most disadvantaged communities. Okay, so let's move on to talk about some of this new data. So Ash has been working with YouGov. YouGov have a weekly COVID tracker, and they've been including questions on smoking since April. They also have they also ask people if they have been treated for various mental health conditions, and that's what this data is drawn from. So I've compared here the smokers with mental health conditions to all smokers. So you can see we asked smokers if they were smoking more or less during since lockdown, and smokers with a mental health condition are much less likely to be reporting that they are smoking less compared to all smokers. You can see that there. So 12% of smokers with a mental health condition say they are smoking less compared to 21% of all smokers. And you know, the flip side is also true. So 38% of people with a mental health condition who smoke saying they're smoking more compared to 27% of all smokers. And also people with a mental health, smokers with a mental health condition more likely to be smoking inside. So this doesn't look like particularly good news. You might think, you know, we definitely have a large group of smokers with a mental health condition in the population for whom their smoking behaviours have intensified during the lockdown period rather than quitting. However, there is good news, because those who are engaged in quitting behaviour do seem to be doing quite well. So here we asked people whether they felt more or less likely that they would quit smoking at this time. And people with a mental health condition, smokers with a mental health condition, as likely really to say that they would feel more like quitting as all smokers, which is pretty good news. And they're also pretty much as likely to say that they've tried to quit. You know, 10% say they've tried to quit compared to 9% of all smokers, pretty similar. But then we kind of get into some differences. So people with a mental health condition are more likely than other smokers to have started using an e-cigarette recently in response to risks around COVID, given that we know e-cigarettes can play a really positive role in people reducing and quitting smoking. This seems to me to be fairly good news. And then I think the best news of all is our figure at the bottom here. So the people who report quitting smoking in the last 4 months. So 9% of our ex-smokers, and obviously ex-smokers are a very big pool of people who, you know, people who quit smoking at any point in their life. But you know, they're significantly more likely if you have a mental health condition and smoke to have quit in the last 4 months compared to all smokers. So for those who have quit or have made a quit attempt, it does seem like now if you have a mental health condition for whatever reason, and we can perhaps talk about that in the questions, people do seem to be having more success with that quit attempt. So the implications for that, I think, is that there is definitely an opportunity to support people, to support smokers with a mental health condition to quit in response to COVID-19. It clearly is something that is resonating with the population of smokers with a mental health condition, and can and seems to be driving quit success. But of course, those who have not quit do appear to be more likely to have intensified their smoking behaviours, and so there is something to be done for that population. And we must not forget that the majority of smokers out there with a mental health condition have increased their, more of them have increased their smoking than have managed to reduce or quit. So motivation to quit is equally high in use of quitting aids, is as or more common than other smokers, but we really need to be getting out there with the quit message and using this as an opportunity to try and level that playing field between people with a mental health condition and the rest of the population, and make sure people have got the support to quit. Very quickly before we move on, I will just highlight the resources that Ash has got up on the Smoke Free Action Coalition website. They're frequently asked questions that I previously mentioned. We've got a communications toolkit which people can use to do various communications activity within their organisation, and template press releases and so forth. We also have pages that are specific on mental health and smoking. Oh no, that's on my next slide. So we've got various other resources to support people, kind of social media stuff, and past webinars. If you've not caught any of our other webinars on smoking and COVID, then they're all on the website. And then we have a specific page on coronavirus, smoking and mental health, which has got some more detailed resources on. I won't talk about the maintaining smoke-free policies because I think that Debbie's going to talk about that later. But just to say that those resources are there and there to help you. And I think that's the end of my slides, and I will stop. Yes.
Brilliant. Thank you, Hazel. Hopefully people are able to hear me a little more clearly now. So we're now going to hand over to Sharon Cox, who's a researcher at Southbank University and is going to be talking to us about supporting particularly vulnerable smokers during COVID.
Hello, yeah, yep, can you hear me now?
Yeah, that's great.
Great, okay. So yeah, I'm Sharon Cox and I'm a Senior Research Fellow at London Southbank. To just be able to move my screen on. Okay, so I've been asked to talk today about how COVID-19 may affect smokers from disadvantaged groups, and particularly how smoking may play a unique role in increasing the risk of contracting or passing on COVID-19. And to do this, I'll be talking about disadvantaged smokers, and I'll define that as those from the lowest socio-economic groups who face multiple health and social needs, so those who might be homeless, dependent on substances, or present with a severe mental illness. I'm going to highlight how risky smoking practices exacerbate the risk of COVID-19, but it's important to stress that COVID-19 is rather a case example, and this can be applied to a number of infectious diseases or seasonal illnesses, which are, the prevalence rates are quite high within these groups. And in addition, I will speak of the risk of increased tacit approval at this time and look at some of the work that we're currently engaged in. So using evidence from behavioural science and disease transmission, this figure has been developed by Robert West and Susan Mickey, and it helpfully illustrates how COVID-19 is transmitted from person to person or from person to object to person. And through using this, we can start to work out how and why COVID-19 prevalence rates appear to be higher amongst certain groups of the population. And we can use this as a tool to work with people to find out where the risks lie. In the case example today, I'm going to use this figure to highlight how and why risky smoking practices place certain individuals at greater risk. Okay, so risky smoking practices, I'm defining those as those which increase the already tremendously high risk of smoking. So they make the acquisition and or use of tobacco even more harmful. You can think of these as adding, I guess, an extra layer of vulnerability onto the smoker. So here on this slide, we're looking at the really common act of going twos, and that is the act of sharing a cigarette that you or somebody else is already smoking. And going twos is really common on mental health wards, in prison, people who are homeless, and anywhere generally where resources and money is tight. We also have the act of asking strangers for a cigarette, which is common amongst adults experiencing homelessness, as well as we know some young people who are not yet at the age where they can purchase their own cigarettes. And both of these acts involve the transmission of a cigarette from one person to another, which could be contaminated. the cigarette, we can think of it as acting as a vessel for the virus, and therefore is easily and seamlessly transmitted from one person to another. Saliva droplets are carried onto the cigarette and then placed into the other person's hand, and then eventually the person's mouth. The next one, I'm not sure if you can you see? Yeah, you can see my whole slide. Yeah. So the next one is the common. So the next one is really common amongst adults experiencing homelessness, and this is picking up discarded cigarettes and either smoking them as they've been dropped, like straight from when they've been dropped on the floor, or using the discarded cigarette to pull out the tobacco to use in one's own roll-up. And both again carry the risk of picking up contaminated cigarettes, possibly contaminated cigarettes. And so here we have purchasing practice. Now, in order to stem the virus, we were asked to socially distance and avoid unnecessary purchases. But if you're a heavy smoker and money is tight, you're on universal credit or some type of benefit, which is around £70 to £100 per week, it's unlikely that you're going to be able to buy all of your tobacco in bulk. And at the height of the epidemic, people would be placing themselves at increased risk through the acquisition of their tobacco. Also using notes, coins which could be contaminated, and visiting people's houses to buy illicit tobacco. All, as I say, add an extra layer of vulnerability. So I've tried to illustrate some of the ways that smoking can increase risk to infectious diseases, but there is also another layer of vulnerability, excuse me, which I think is worth exploring. We know that smokers will be feeling stressed out. It's been a really frightening time for many. Anxieties will be high, money tight. And it's worth reflecting here on the good qualitative evidence that we have from the UK that has highlighted that for many of the smokers I refer to, those with hard lives and in times of stress, they're actually sometimes talked out of smoking. We do see evidence of this in the literature. And this is a real risk here that is not necessarily generated by the person's smoking habit, but indeed created by health and social care professionals. In times of stress, smoking is even viewed as beneficial for some, and in times of uncertainty, like when people are moving accommodation or their anxiety is high, they might be going in and out of rehab, smokers can be told that now is not the time for you to quit, like this quote illustrates. So it's really important, I think, that we're aware of our own biases, and smokers are not told that now is not the time because there's too much going on, too much uncertainty. Because actually the evidence is that smoking benefits people's mental health, which I know other speakers will probably talk to. And I would think also, without so many of the usual environmental cues associated with smoking, this may be a good time to change one's behaviour. As Hazel has shown, there is an uptick at population level in quit attempts, and some of that is filtering down into the most vulnerable. But as Hazel also said, that if we don't keep up this rate, or if people from the lowest socioeconomic groups are not encouraged, then COVID-19 will, runs the risk of also increasing the divide in tobacco-related inequalities, and that's a real concern. So I've just summarised what I've shown in this table. Okay. So now I'd just like to quickly talk through this project that I've been working on with the principal investigator, Professor Lynn Dawkins, a colleague of mine at Southbank. And I want to show this project to demonstrate how harm reduction can also be viewed as assisting infectious disease prevention. We received funding for an 18-month feasibility study exploring the uptake and use of e-cigarettes and usual care to smokers accessing for homeless services. So I don't have time to go into detail, but those in usual care were offered details of their local stop smoking service and were signposted there, and a help to quit leaflet. And those in the e-cigarette condition were given a starter pack, including e-liquid for the next 4 weeks, and they were given that at the homeless centre that they were already accessing for support. So we recruited 80 people, and as you'll see in this slide, this is a group really presenting with multiple needs, including poor mental health and a really high prevalence of learning needs. So in relation to my slide on tacit approval, nobody was excluded from this study. As long as you were a smoker and you were known to the centre, you were able to enrol for the study, and that was really important to us to make sure that we were reflecting the demographic. So people that enrolled in the study were currently using substances. Some people were rough sleepers, had extremely poor mental health, but everybody was included. To show you the 12-week outcomes, that's not necessarily the point for this presentation, but you may be interested. So the 12-week quit rates in the usual care arm, we had 0 people fully quit in the usual care arm at 12 weeks, but in the e-cigarette arm, we had 3 people report sustained abstinence, which was CO verified. We also saw a really good reduction in CO in our e-cigarette arm. But more relevant to this presentation is the other harm reduction markers. So if we take a look at sharing cigarettes or going tos, looking at this for only those who came back for follow-up, so we controlled for confounding factors. For those that came back for all of their follow-ups, we saw a real reduction in those who reported daily sharing of cigarettes, and as I've tried to highlight there. So similarly, for those picking up discarded cigarettes, again, only for those that came back for all the follow-ups, the number of people who said not at all rose, especially at 12 weeks, and then it does dip back down again. So what we're tentatively concluding there is, while we are present and the study is going on, people are being supported, we do see some changes to this behaviour. And again, asking a stranger for a cigarette, a positive rise in the number of people who say they are not engaging in this behaviour, and also a decrease in the number of people reporting occasionally. So it appears that they move from that category into another. So, you know, quitting smoking, or at least reducing, has this added benefit of harm reduction in so many other ways, making further positive health changes in addition to the well-known benefits of quitting. Just to add, I didn't add it onto the slides, but I thought people might want to know. We also showed that, again, for people that came back, we saw a positive increase in people's self-reported anxiety and depression scores. And we also, again, for people that came back for all the follow-ups and were still using their device, saw a positive increase in alcohol reduction, but we saw no changes at all to substance use or dependence scores. So the study I've just shown you is currently under review of our funder. That's the final report. That's the NIHR. But we do have some other work going on. So we have a Cancer Research UK funded study where we're monitoring smoke-free policies across homeless centres. And we've added some additional questions around how people have, how services have reacted to COVID-19, because we know that there's some really good work going on out there at a local level with homeless services teaming up with their stop smoking services or with vape shops. We've also, this is unfunded, but we've got a survey of stop smoking services and vape shops, including changes to business as usual during COVID-19. And also we're trying to work out how have services worked with disadvantaged smokers in particular, and how have they tailored their service to those that may be on the shielding list, because as we move forward, we really want to identify new ways of working and perhaps identify some good practice. And then at a more broader population level, the smoking toolkit study, there have been some additional questions. So in addition to the monitoring of smoking and smoking cessation at a population level, we've also added in some questions around transmission related behaviours. So have people adapted the way that they smoke, or the way that they purchase their tobacco in light of COVID. So that's it from me. There's a couple of things here that I've written, a bit more detail than I was able to present today. They're open access if you're interested, and the slide with the figure on it, The Roots of Transmission of COVID-19 by Robert West and Susan Mickey, is open access. You can just click on that link. And that's all. So thank you very much.
Brilliant. Thank you, Sharon. And some really interesting content in there. Just a reminder for everyone to send in your questions for the panelists via the panel at the right-hand side of your screen. So if you open that up, you can type in there and send us some questions. We're now moving on to Debbie Robson, who works at King's College London and is going to be talking to us about transitioning and liaison between inpatient and community services. Debbie, if you're just able to click the arrow on the panel at the right-hand side of your screen, for some reason that seems to be showing to us, but if you just click on the arrow at the top there, you should be able to remove that.
Arrow at the top.
So that's the one. There you go.
Okay.
Perfect.
I'm sorry I can't get rid of the bottom of my screen. I've no idea how to get rid of that. Anyway, good morning everybody. I'm Debbie Robson. I'm a mental health nurse and a tobacco addiction researcher at King's College London. And in the next 15 minutes, I'm going to briefly touch on the scale of smoking in mental health services and particularly focus on the role community services and the information that they need to exchange with inpatient colleagues around tobacco dependence treatment for people with mental health conditions, and say something about how to manage patients' expectations so that they have a much better experience of tobacco dependence treatment, either in the community or in inpatient services. And I can't seem to move my screen on. Okay, there I am. So last year, there was around 2 million people who were in contact with mental health services, and the vast majority of them were supported in the community. So 95% of people get their treatment in community services. But we spend most of our money and we've dedicated most of our resources around tobacco dependence treatment and smoke-free policies within those inpatient services. The problem is we actually don't know exactly how many people in those services are current smokers, because NHS trusts are not mandated to report this information centrally. So we have to estimate how many smokers are in the system from annual surveys, and annual surveys don't often get filled in by people with severe mental health problems. And we've also got to look at local data. So I've estimated that there's probably at this moment between 500,000 and 1 million smokers who are using community mental health services. And in hospital, it's around 50,000 people. So that's quite a lot. And half of those smokers, they're going to die prematurely, and they're going to be in really poor physical health. And their smoking is going to contribute to more severe symptoms of psychosis. They're more likely to be depressed, and smokers will spend much longer time in a mental health hospital and an acute hospital as well. They'll be prescribed higher doses of some medicines, and they'll be in poverty, and they'll be exploited, and they'll be stigmatized from their smoking behaviours, such as Sharon was mentioning, like begging for cigarettes and picking up cigarette butts from the pavement. And there's a growing evidence that if you smoke every day, and when you're much younger, it's associated with an increased risk of psychosis, and your psychotic illness is likely to start earlier than people who don't smoke. So tobacco dependence, it's an urgent clinical condition, and it's a relapsing chronic condition that usually starts in young adulthood, or in some cases in childhood, but it's a treatable condition. And people who smoke and the staff who look after them, they need every available tool to help them manage their tobacco dependence whilst in the hospital and in the community. And there's never been any more tools in that toolkit to support you to help smokers than ever before. So you've got a whole range of licensed medicines to help people stop smoking. You've got e-cigarettes, and you've got behavioural support. And mental health nurses and psychiatrists and their allied health professionals, they've got existing skills that can be easily adapted to support people who smoke to reduce their harm from tobacco. So wherever you are in the patient pathway, whether you're going from home into hospital, hospital back home, or you're kind of cycling between the two, Staff need to be offering very brief advice to everybody. So we need to ask. Sorry, I was distracted. There's a bee in the room. You need to ask every patient if they currently smoke or if they've recently stopped smoking, because an admission to a psychiatric hospital could be a trigger for a relapse to smoking if they've just recently stopped. We need to record that in the clinical notes, and we need to be asking people regularly, so at every CPA review. We need to be advising and offering support. We don't need to get into conversations about how interested are you in stopping smoking, or are you interested in stopping smoking, because that's not particularly helpful. We just need to be offering support to every smoker. So saying things like, did you know that stopping smoking is one of the best things you can do to improve your physical and mental health? Because we've known for some time that it's offering support to quit rather than asking smokers how interested are they stopping or telling a person they should stop smoking that leads to more people making that quit attempt. And then the ask bit is different depending on whether you're working in the community or whether you're in an inpatient setting. So for those of you who are working in the community, we need to be having regular conversations with people about making sure that they know that the hospitals, acute and mental health, are smoke-free, and having discussions about what that means for that individual person. What to expect if they have to go into hospital. So what medicines are available in your local hospital? What's the e-cigarette policy of your local hospital? And then if you've got a local community stop smoking service, then refer people to that service, but work in partnership with them. Don't just refer them and then kind of back off and forget about them. Or if you're lucky to have a trust that provides level 2 training, then provide that stop smoking support alongside their mental health care. I'm going to talk a little bit about advanced care planning to prepare people for planned or unplanned admissions. And it's really important that we make sure that people who've quit in hospital or reduced their smoking in hospital are supported to maintain and build on that progress. And for those of you who are working in the hospital, I'm guessing by now, because we've had 6 years of smoke-free policies, hopefully you're offering prompt access to NRT as soon as patients are on the ward, and you're supporting people through a smoke-free admission, whether that's to be temporarily abstain or to quit completely. And also to maintain a smoke-free environment. So, for example, no staff-facilitated smoking or storage of tobacco. And Hazel mentioned earlier about some of the resources on the Mental Health and Smoking Partnership website that we put together at the beginning of lockdown, or just prior to lockdown, because what we were hearing from around the country, trusts were reinstating their smoking breaks, either in gardens or off-site. And as Sharon mentioned, this had the potential to increase the transmission of respiratory conditions and COVID-19, because we know that when people are given smoking breaks in their gardens and they're confined to really small spaces, it increases the risk of violence, and it increases the risk of people engaging in those risky smoking behaviours. And now, it's more important ever that we keep wards as calm as possible to manage the high levels of stress and anxiety that are in inpatient services at the moment. So working in partnership with community stop smoking services, either if you're referring people into the community following discharge, or whether you're working in a community mental health team, there's some information exchange that needs to go on. So mental health teams need to know some information from stop smoking services, like is the patient stopping all in one go, or are they gradually cutting down, because that might impact on the metabolism of some of the psychiatric medications. They need to know what medicines the stop smoking service are giving them. Are they giving them varenicline, or are they giving them NRT? Because community staff can help promote adherence to those medicines. And they also need to know from the stop smoking services, are patients, experiencing any withdrawal symptoms? because the withdrawal symptoms often get confused with mental health symptoms. And then they also need to know, did the patient actually quit? And what we know from our local stop smoking services, sometimes the information doesn't flow back. You refer people to community stop smoking services, but you never then find out what happened to that patient. And likewise, the stop smoking service needs to know from you what psychiatric medications are they on. So they know for interactions to watch out for. What are the early warning signs? Relapse, what the early warning relapse signs, mental health relapse signs patients experience. But also any changes in mental health treatment, any new risks that are occurring. In terms of if you've got community staff who've had level 2 training and can support people alongside their mental health care, then I direct you to the work of colleagues in York and the Scimitar trial, who did quite a fantastic randomised control trial with 500 people with serious mental illness, and provided them with behavioural support and NRT, which doubled the quit rates of people receiving that support. And that was delivered by community mental health staff. In terms of advanced care planning, there's lots community staff can do to support people who are either have got a planned admission or an unplanned admission. You'll all have people on your caseload that you can reliably predict that are going to be readmitted time and time again. So there's lots of work you can do in terms of getting ahead of some of the problems that might occur if you're admitted to hospital and you suddenly got to stop smoking. And it's much easier if you can make those plans and practice those plans when you're mentally well. And if you can establish those coping strategies now when people are well, rather than when they're acutely psychotic or when they're in the state of tobacco withdrawal. Supporting people after discharge is really possible, so make sure the ward team include NRT or varenicline or e-cigarettes as part of the take-home medication. And make sure patients know how to access where to get future supplies from. And make sure people know how to use the products correctly. And you may need to support prescribers in tweaking their medicines. Managing expectations is, I'm just going to quickly run through these because I can obviously send these slides out. But in terms of making sure people don't underdose on NRT and use sufficient of it is really, really important. Making sure they know what to expect about how satisfying NRT is. And a lot of people don't find it satisfying because it can never ever replace the amount of nicotine you get from a cigarette, and it can't replace it as quickly as enough. So you'll get lots of patients saying, I'm not having that NRT, it's a load of rubbish, it doesn't work. That's largely to do with how long it takes to get into your blood. Make sure people are using the right techniques, so that they're chewing and resting and chewing the gum, and they're sucking and resting and using sucking the lozenges. Because if they don't have the right technique, then it's just not going to work, and you'll get an upset stomach and a sore mouth and hiccups. Make sure people know that varenicline is the most effective single medication for people with and without mental health problems, and it doesn't increase the risk of neuropsychiatric side effects, and that increases the chance of quitting fourfold. And with e-cigarettes, approximately up to 20% of people with a mental health condition are current vapors, but most of them also smoke. And so they're not reducing the harm they're getting from tobacco compared to if they were completely switching from smoking to vaping. So it's really important to have those conversations that e-cigarettes really, really helpful and effective, but you need to stop smoking completely to have the best effect. And there are studies for e-cigarettes for people with mental health problems. And the ones that do best, the e-cigarettes that do best, are the more kind of recent products and high strength nicotine products. And finally, psychiatric medicines. The dose of some medicines are going to need changing after people are admitted to hospital, and that's depending on how much you smoke, the type and dose of your psychiatric medication, and how adherent you are to your medication, and then how restricted you are from smoking when you're in hospital. And you might be restricted initially when you go into hospital, but then you might get some leave, and so you start smoking again. And then, so plasma levels of some medicines are going to change throughout admission, and then they'll change again after discharge if you resume smoking. And it's not the nicotine that's causing this effect. It's the tar in the tobacco smoke that speeds up the production of particular liver enzymes. And we're not concerned about every mental health medication. We're only concerned about the medications that are induced by one particular liver enzyme. So smokers need much higher doses of these meds compared to when they stop smoking or abstain from smoking. So when people stop smoking, the metabolism of the medicine slows down, so it stays in your body much longer and it builds up. And so you need to reduce the dose of that medicine to prevent side effects and toxicity. And what's happening, or what's kind of been happening since services have gone smoke-free, there's a constant changing of blood levels of medication, particularly of clozapine and olanzapine and haloperidol, and it's really quite tricky to get that right. So close liaison with the inpatient community primary care colleagues is needed. So to summarise, we need to move to a position of mandatory recording and reporting of smoking status within the NHS. We need to be better at exchanging information between community services and stop smoking services and inpatient services, as well as integrating tobacco dependence treatment within community mental health teams, which would be the gold standards. And then advanced care planning and managing expectations to improve the experience of smoke-free admission will help to drive down smoking prevalence. And we need to have some close liaison with our service users and families, community and primary care and inpatient settings, to make sure we're not making some mental health conditions worse through the ineffective use of mental health medicines. Couple of resources, Mental Health Smoking Partnership and some of the work we do with the NCSCT. You can find all these resources in either one of these websites. So thank you very much.
Thank you, Debbie. That was brilliant. And we've got some questions coming in here, so there'll be things to ask you in the Q&A. We're going to move on now to Dr. Gemma Taylor from the University of Bath. And Gemma is going to be talking to us specifically about IAPT services.
Hello, everyone. I'm just loading up my screen now. Okay, so I hope everyone can see that. So today I'm going to be talking about some work that I'm doing in IAPT, which is a primary care health service for people with common mental health disorders, so predominantly anxiety and depression and mixed illnesses. That image there looks a bit odd, but it was an image that we actually collaborated on with a local artist about the work that we're doing in IAPT. So I like to use that whenever I do a presentation about this work. So just trying to switch my screen now. There we go. So those are my disclosures. I'm currently funded by Sierra UK. Some of the work that I'll present today was funded by Pfizer and NIHR. So the study is ongoing. So I'll be sending you, I'll be presenting to you some preliminary data today. The first piece of work that I'll be presenting was some qualitative work that we did with IAPT PWPs. They're the psychological well-being therapists or practitioners. I'll probably refer to them as PWPs or therapists, and patients who are service users of IAPT. And then I'll present some preliminary data from a pilot and feasibility study that we're running in IAPT. So my colleagues have done an excellent job in presenting the nature of the problem of smoking and mental health and all of the health inequalities that go along with it. So I won't speak too much about it, but I will just show you smoking prevalence rate stratified by people with anxiety and depression and people with no mental disorder. This is from the CPRD, which is a massive primary care database of over 30 million clients. We analyzed this data a few years ago and published it last year. But what it clearly shows, which you won't be surprised, is that the smoking rates in people with anxiety and depression are much higher than people with anxiety and depression without any mental disorder at all. So it's around 3 times higher. And there's little evidence that it's changing. It's slightly going down, but nothing impressive. So the work that I'm doing in IAPT was really inspired by a paper that we published a few years ago that we're currently updating, showing that when people quit smoking, their mental health improves, and the size of that improvement was about the size of taking antidepressants. So, you know, this led us to think, actually, why not use smoking as a treatment or quitting smoking as a treatment for mental health? So, you know, smoking cessation should be integrated as standard part, a routine care for mental health, given the potential size of the benefits that one can obtain from quitting. So we conducted some interviews with IAPT patients, PWPs, and also some local stop smoking advisors. I won't be presenting the data from the smoking advisors. I'll just focus on the IAPT data today. But the reasons that we conducted these interviews were to understand views about treatments for tobacco addiction and common mental illness, understand views from the therapist and from the service user perspective about integrating smoking cessation treatment into IAPT. Did they buy into this idea? And also to collect some data to inform a smoking cessation intervention and a trial of the intervention for integration into IAPT services. So I'll be presenting a select number of quotes, a little bit of data, just to give you a bit of a taster, and any questions, or if you want to know anything else, just ask me in the question session. And also we've got the reference down there. We've just added a preprint to MedArchive of this data. So we asked people, you know, we asked the clients and we asked the therapists, what do you think about stopping smoking as a treatment for mental health? So something that you can integrate into IAPT care to help people improve their mental and physical health. The patients bought into that idea. The service users, they tended to be on board. I didn't have anyone say that they didn't think that it was a good idea or that they felt that it was something that was inappropriate for IAPT. So here's a quote from one IAPT client, and she said, "Stopping smoking as a treatment for mental health would make me more likely to want to do it." And she actually liked the idea of framing smoking cessation as a mental health treatment, something that can help your mental health, rather than just trying to shoehorn smoking cessation treatment into any old service. And from the IAPT, from the PWPs, the therapists, they were all on board. They, you know, so this one therapist in particular says, smoking seems to be the only health behavior that we don't really touch. So I think it would fit really nicely in the IAPT service. You know, she spoke about how they work on sleeping, they work on eating, they work on exercise, caffeine, they even work on alcohol. They work on all these lifestyle behaviors except for smoking. So she thought it was a bit of a no-brainer. One of the, I guess, apprehensions that patients can have, that clinicians can have, and even from a researcher perspective, is integrating smoking cessation treatment into a service that's aiming to improve people's mental health, when we know that quitting smoking, people can experience withdrawal symptoms that are mood related. And we also know that people with anxiety and depression experience mental health related withdrawal symptoms like low mood and anxiety much more intensely than people who don't have anxiety and depression. So I broached this question to clients and to therapists and asked them, how do they feel about that? And I was surprised. I didn't know what to expect, but I was surprised at how positive they were about it, the therapists. So we've got some quotes here from two therapists, from the same therapist. And she said, if patients are feeling worse mentally, then it's a safe place for them to tell us. We assess their risk at every single session. And she moved on to say that as long as patients are aware that they may feel worse during the withdrawal period, and that it can be difficult during the withdrawal period, but the therapists are there to support them. And she went on to conclude that the end goal is still to get them to feel better in the long term. And if they can do that while they're in the support of a trained psychologist, then she thought that was the better option. So I felt that was really reassuring. So in terms of training, so sorry if you can hear my dog barking. So I asked the therapist what they thought about training and service requirements. So they like the idea of offering smoking cessation, but is it feasible in terms of their training, and are there any barriers or issues in the services that we might need to overcome first? And the therapists all agreed that they had the skill base in terms of the behavioral skill set, behavioral interventions. This is what they do every day. It's their bread and butter. They help people who may be suffering from low motivation, who may be feeling anxious about changing behaviors, and they help them change lifestyle behaviors. They help them improve their mental and physical health. So they were on board in terms of the skill base. They just said that they needed some extra training in terms of the evidence and the research base for quitting smoking and mental health. Some of the service requirements, this won't be a shock to anyone, but a lot of the PWPs mentioned that it's an already stretched service. Really what they would need is to have either longer sessions or for their caseload to be slightly lowered. So that's a bit of a message to commissioners, really. I do know some local commissioners that are interested in integrating smoking cessation treatment into their services based on some of the work that we're doing. But I think it might be something that will have to be considered quite carefully. Which does bring me on quite nicely to the trial. Just on that last point, we are testing two models of integrating smoking cessation treatment. One where services actually give the therapist more time, and another model where the therapist need to offer smoking cessation treatment within the normal therapy session. So we'll see how that goes at the end. So the idea of the pilot and feasibility trial. So we're offering parallel treatment of smoking and mental health in IAPT. So the client gets the smoking cessation treatment from the same therapist in the same session that they receive treatment for their anxiety or depression. The treatment is delivered in one-to-one sessions at the moment, over the telephone or face-to-face, over the telephone mostly now because of COVID. Inclusion criteria, we've kept this very pragmatic. And we're including people with anxiety or depression who smoke daily, but who are eligible for the service. So sometimes what you might find is that people don't meet caseness for anxiety or depression, and maybe they actually have minor symptoms of OCD. But as long as they're eligible for IAPT, they're eligible for this trial if they're an adult. Typically, the smoking cessation intervention is being offered over 5 to 15 minutes per therapy session, with around 6 sessions per client, depending on their usual mental health care. And then it's a combined smoking cessation treatment. So they'll be getting smoking cessation medicine, so NRT, varenicline, or e-cigarettes. They'll be getting behavioral support from their therapists, and also the therapist will focus on the mental health benefits of quitting smoking, and really look at integrating the mental health benefits of quitting smoking into a CBT cycle, or to a cycle of what do they call it? A vicious cycle. So we're still recruiting. So we're hoping to get to 160 people for this trial. We've got 4 sites. We've got Oxford, Avon and Wiltshire, Northeast London, and Black Country. Northeast London and Black Country, they're just about to start recruiting over the next few months. We've recruited so far 72 people. TX means treatment as well. So these are some baseline characteristics. I've kept the treatment arms blinded. That's the way that we need to present the data until we've completed the trial. So I don't know which arm is which. But what you can see is that the population we're working with are predominantly female, predominantly white. I've not presented the education data, but they're quite educated. They are quite unwell in terms of their PHQ-9 and GAD symptoms. It is typical of this population that in IAPT that this tends to be, I guess, generalizable to the IAPT services that we're working with. So from what I can tell so far, it's not that we're just recruiting people who are white and educated. It just tends to be that way in the services we're working in. Although that obviously has implications for the study. But what you can see is the arms are relatively balanced here. So some of our follow-ups. So what we're really interested in terms of for the feasibility outcomes are whether or not offering smoking cessation treatment impacts negatively some way on their mental health treatment. So does it stop them from attending IAPT? Is sort of that's the big question. So what we really don't want to see is differential attrition for the first and third row there. So number of do not attend, so that's people just not showing up to an appointment. And you can see that that's equal between the arms. And then also withdrawn from IAPT. So people who leave their IAPT treatment early, and you can see that that's also equal. We have a higher prevalence of self-reported quits in one of the treatment conditions, and a higher prevalence of CO verified quits in one of the conditions as well. Some other data that we're collecting interview data with IAPT therapists and participants as we go. And so far the feedback has been positive. And it's also been great because we've been doing the interviews alongside intervention delivery. So if there are hiccups and things, we're actually able to iron these out as we go along. And we're also working on collecting some implementation data. So listening into the intervention sessions and seeing what's going on and marking that against the checklist. As you can imagine, COVID's had some impact on the study. We have been on hold for 3 months, but things are really, really grateful that things are starting to open back up. And we've also changed our biological measure. We're now collecting saliva samples rather than CO monitoring, and we're looking to end recruitment next year in August. So that's all from me, and just thank you to my colleagues, my research group, AIM in the University of Bath, and my dog there. Thank you.
Thanks, Gemma. It's Hazel here. So in the kind of spirit of working from home, in the course of your presentation, Vicky's been evacuated from her flat due to a fire alarm. So I'm just going to take over chairing. And we'll do some questions. I'm just going to see if I can unmute our other panelists. Debbie and Sharon, you are now unmuted. So I'm going to ask myself a question first, and then I'm going to ask the rest of you some questions. There was a question that I should have addressed when I presented the data that I did, on the sample size, etc. So it's an online panel survey, so they're all self-reported. There were 268 smokers with a mental health condition in the sample, and just over 1,400 smokers in total in the sample of the data I presented. I'd also ask people not to share it at this stage because we are going to be publishing it and we haven't quite managed to do that yet. So don't stick it on social media just yet. And we'll also be circulating the slides and in this recording, so you'll be able to go back and look at anything that you found that was interesting. Right, so now I need to go and have a look at these questions and ask some of the rest of you some questions. Gemma, I was just, while I'm looking them up for the others, as you were talking, I was wondering if you might reflect on what you think the role would be of IAPT, and particularly around supporting smokers, given that we're expecting a kind of mental health fallout, I suppose, from lockdown and potentially almost certainly a recession. Whether you think there's a particular opportunity or benefit to having smoking cessation located with IAPT in this circumstance.
Yeah, definitely. I mean, I think we're in this trial specifically, we're targeting people who are interested in quitting smoking. And there's lots of other opportunities in IAPT that we're looking into. They offer online treatment as well, which is something that we're looking into. So I think, we are about to have, are currently probably having, we'll see the, data soon, but a mental health crisis from the impact of COVID and increase in anxiety and low mood from social isolation. And if people present to IAPT and they smoke, and they want to help improve their mental health by quitting and also receiving therapy for their anxiety and depression, I think they should be offered that. They'd be offered help for caffeine consumption or alcohol consumption or increasing their exercise. So I think quitting smoking just falls quite nicely into that.
Cheers, Gemma. Right, Debbie, we've had a few questions around varenicline and the kind of continued resistance of some prescribers to provide varenicline to people with mental health condition. Is there anything more that you could speak to, in response to it? There's at least 3 people who've asked questions about how they can convince prescribers that they, this is a safe drug to provide to people with mental health condition. I wonder if you could speak to that.
I think it's really tricky. So I think when for those people who've got a education and training role, then I think breaking things down, so explaining why varenicline might be particularly useful, and showing particularly the Eagles trial in terms of that head-to-head data of sort of something like, I've got my slides up now, something like 23% of people quit with NRT, but 33% of people quit with varenicline. And I think what's helped us most is gathering stories of success from service users who've used varenicline and presenting those back to prescribers and presenting those, going along to your drugs and therapeutics committee and getting your chief pharmacist on board. And then wherever you can, so educate pharmacists, but educate your prescribers, particularly psychiatrists, who seem to be a big barrier for prescribing varenicline. And if they won't prescribe it during an inpatient admission, then work with people post-discharge to prescribe it. So don't completely cut off that option for them, but maybe wait till they're further along in their mental health pathway to start it.
And there is that briefing as well, which RC Psych produced on varenicline. So we might circulate that as well with the various other things we'll circulate after this this webinar.
Yeah.
Obviously, the Royal College backing the use of varenicline there. And also in that statement, sorry, Debbie.
Sorry, Debbie? I was also, can you hear me?
Yeah.
Yeah, so I think also the fact that initially when varenicline got its license, it was for people who that you set a quit date 2 weeks after you started your medication. So people would continue to smoke for about 2 weeks, and things have changed over recent years with that. So there's guidelines on using varenicline for cut down to quit, or not just abrupt cessation. And you can give people a nicotine inhalator for the first 2 weeks if they're in hospital, and varenicline's being prescribed. So there's plenty of resources out there as well for supporting inpatients to have varenicline.
Thanks, Debbie. That's a really important point, because I think people often think about it as a medication that wouldn't be useful in that circumstance, because, as you say, that sort of legacy thing about setting a quit date 2 weeks later. There's some questions around e-cigarettes, and I think it's to come to you, Sharon, and then maybe also Debbie's view. I'm just going to read it out from Chris here. E-cigarettes have recently been by far the best accepted smoking replacement product for our mental health inpatients in Dorset. Could we do better at advising smokers on which products are likely to help them most, given the overwhelming choice, i.e. simple pod type devices using nicotine salts, e-liquid for speed of delivery and a smoother, more cigarette-like experience, and also supplementing with a patch for heavier smokers given their nicotine limit. Sharon, would you comment at all on how to advise people around the types of products and what might be more acceptable for different types of people and types of smokers?
Yeah, definitely. Yeah, it's a really good question, and we don't actually have that type of evidence where we we can say that if you fall into this category, then you should definitely use this type of e-cigarette. So at the moment, we're using a lot of user experience and common sense, and some evidence from some observational studies. But I think Debbie pointed this out, that the newer devices are the best in terms of nicotine delivery. They're also easier to use. So often people don't want to spend very much money, or they think they might want one of the Cigarlight cigarettes because they look like a cigarette. Well, work by Jonathan Folds in the US has shown that Cigarlights just, they don't satisfy people's nicotine cravings. They're not the battery's not powerful enough to give people that nicotine hit. And if you're talking about someone who's quite a dependent smoker, a newer device doesn't have to be expensive, but a newer decent device is what people want to go for. What I would say is that, and certainly we found in our work, is that people who successfully switch don't always end up completely switching with the product they first purchased. So they might buy or be given an e-cigarette, and if they're really encouraged to use it, and they're encouraged to try a range of flavours and nicotine strengths, and engage with advice, there's loads of user advice online, then people slowly make their way through to a combination of products, strength, flavour and device that they really like. That's why I think it's quite important that we're able to offer these products to people at first, so that there's not this startup expense for people experimenting, because the groups that we're talking about, they don't necessarily have that financial ability to keep experimenting. I hope that's
Thanks,
helpful.
Sharon. That's really helpful. I won't come to you, Debbie, because we're in the dying moments of the webinar. I wanted just a very quick last thought from each of you about, right now we're in a kind of complicated situation, but I think it's clear that there is an opportunity to support more smokers with a mental health condition to quit right now. What do you think would be one of the most important things which services, people in contact with smokers with a mental health condition could be doing to motivate smokers, to support them at this time? That's a tricky question, I know. Should I come to you first, Debbie? That's somewhat unfair. One very quick thought before we close the webinar.
I guess a very quick thought is don't abandon your smoke-free policies. Don't undo the years of hard work and fierce conversations you've had with people during this difficult time, because now more than ever, smokers need your support to reduce their tobacco dependence.
Gemma.
Thanks. I think I completely agree with Debbie. Just to add to that, it's worth, when doing consultations with clients, just to remind them of the mental health benefits of quitting, and actually in the long term, what we see is that people's mental health improves after quitting smoking.
Yeah. And Sharon, you've got the final word.
Yeah, I would just say that sometimes people fear losing something when things are uncertain. So I think that if we talk to people about switching, like switching to an e-cigarette or switching to get your nicotine from a cleaner source, then there's, you know, you can help people to not think about losing something, but actually gaining something.
What 3 great messages to end on. So thank you to everybody. Thank you to Vicky for sharing as far as she was able to. We obviously will be circulating the recording, circulating the slides, bits of follow-up information. Please fill in the evaluation. It's very helpful to us. We also plan to do some more kind of community mental health focused webinars throughout the rest of the year. The next one will almost certainly be on training, and we're really keen to hear from people about what else they might want us to cover across the rest of the year. So drop us a line or fill in the evaluation and let us know. Thank you, everybody, and stay safe and have a lovely weekend.
Thank you.
Bye.
Bye.
Bye.